Hi, everyone. Welcome to today's webinar, A Usable Guide to EEG and Medication, with our guest, Corey Williams. Welcome, Corey, and thank you for being here.
Thanks for having me. I appreciate it. So today we're going to go over a guide for how medication can impact the EEG and also how we can use the EEG to maybe make smarter medication choices or maybe better educated medication choices. Maybe smarter is not the right word, but both pieces are going to be in the guide. This guide that we've been working on in our clinic for 7 years or so is slowly being adopted by the ISNR, and it's going to become a resource that is available for free on their website. We're hoping by January. So normally I would say I'll make sure everybody who participates in this discussion gets a copy of our medication guide. But in this particular case, I would say just wait a few months and get it from the ISNR where it will be official. Let's go ahead and get started here. So financial disclosures, I have none. I work at a clinic in Nashville. The way that we put this guide together is that every time someone came in to our psychiatric clinic, I would ask what medication they were taking, and then I would look up what EEG effects are noted from that medication. Very special thanks to all the people along the way who contributed to this. The list is, I'm sure, longer than this, but these are some of the people who had some direct input. I did not do this by myself, and I would hate for anyone to think I was the sole proprietor. A lot of work went into this from a lot of people, so thanks to all of them. My background, I was a teacher for a bit. I got into the field of neurofeedback, where I worked in a neurology office under Dr. Turner. I earned my degree in psychology, and then I moved from neurology to psychiatry. And when I made that move, I realized pretty quickly that in the field of psychiatry, a lot of people take medications, and a lot of those medications are not super well documented in terms of what their effects are on the EEG itself. So this is how we put together this guide. Like I said, I would ask people what medications they take. I would research, look for articles about that medication as it relates to EEG, and then slowly this thing kind of came together piece by piece. So what are some learning targets here? What do we all expect to get out of this? Hopefully, by the end of this presentation, you will be able to define what is and is not within the scope of practice, to be able to confidently discuss medication choices with other health providers, to identify common phenotypes and how they respond to medication, and to use the accompanying spreadsheet to effectively guide medication choices. Okay, so before we start talking about this guide to medication, we need to talk about scope of practice, because this is really, really important. If you look at the BCIA website, right, and they do certifications for neurofeedback, you look at all the different people who can get certified to provide neurofeedback. We've got psychology, medicine, nursing, PT, OT, social work, counseling. You know, this is a huge list. Even music therapy in the right setting can provide neurofeedback. Now, some of these people can make recommendations about medication. Some of these people can prescribe medication, and some of these people can't. And so it's really, really important to learn what the state that you live in says about your scope of practice and what you are allowed to talk about when it comes to medication with your clients. If you are a prescriber, then feel free to talk about medication. Although if you are not the prescriber in a particular case, you might want to think about whether or not it's ethical to second guess another provider's choices. That's a whole separate conversation. If you are not able to if you are not able to prescribe medication, I would highly, highly encourage you not to talk to the client about it at all, and instead to have that conversation with the prescribing provider. The only person who is responsible for knowing your scope of practice is you. So you have to check with your state boards. It's even more important if you're using stimulation or neuromodulation techniques. Neurofeedback is one thing, giving the brain electrical current or magnetic current or photobiomodulation, that's a whole separate thing. So just check with your state boards, make sure you're within your scope. Like I said, if you can't prescribe medication, don't talk to the client directly about medication. And part of that means you have to become very comfortable answering questions by saying, that's outside of my scope, I can't really talk about that. I say all the time, because I work for a psychiatrist, that's a great question. You should ask your doctor the next time you see her. So with all of that said, sometimes we do have to talk about medication, right? We know if we use this guide correctly, or if we look at somebody's EEG, we can make a better guess about what type of medication is going to work more effectively. So I think it's always best to have that discussion with the prescribing provider. When you talk to your client about medication, sometimes they will mishear things, sometimes they will misinterpret things, sometimes they will fill in gaps of knowledge that you did not. And you don't want to get a call from a psychiatrist asking you why you told their patient to stop their medication cold turkey, right? That's a sticky situation that you don't want to be in. So my recommendation would be, it's always best to talk to the prescribing provider about the medication that the client or patient is taking. When you have those conversations, first make sure you get an ROI so you can share information, including sharing your EEG or QEEG report. Be comfortable discussing EEG results and brain phenotypes. I think one of the ways that I have made the most progress in this type of conversation is to talk to providers about whether a client has a fast brain or a slow brain. And there's lots of ways we can define those things, right? But it helps a medication provider if you're able to say, hey, this client's baseline brain speed is really, really fast. We want things that are going to slow it down or calm it down. We want medication that is less activating. That kind of language I have found lands pretty well. Be prepared to cite the literature. So there's a bunch of papers. We'll mention some of them here. But know those papers, have copies of those papers, give them out like candy. And then the last thing here is to make suggestions, not demands. When you talk to prescribing providers, especially if it's outside of your scope, don't tell them they have to make change X, Y, or Z to someone's medication. Just say, according to the literature, you might have more success with your client if you try X, Y, or Z. Okay, so that's a little bit of background about kind of knowing when to talk about meds and knowing how to talk about meds. So let's take a look at the guide that we put together, and we'll talk about where and how to use this in this bigger conversation about medication. So this is a sample page from our guide. Okay, in it you'll find the medication, the class, the reported EEG effects, indications and cautionary factors, common side effects, and the half-life. For all of these meds, the reported EEG effects, this is not research that we conducted in our clinic. This is research conducted by other people that we have collected. The reported EEG effects, I think of them as similar to common side effects. So if you look at, say, amitriptyline, some people who take it get drowsiness, some people get dry mouth, maybe some people get both. You probably don't have anybody who gets all of the side effects, maybe one or two. It's the same way with the EEG effects. Some people get increased delta, some people get increased theta, some people get both, some people get none. It's going to vary person to person. It varies on a whole host of factors: their genetic makeup, their diet, their exercise routines, what their underlying brain chemistry already looks like. So many factors go into which of these things we may or may not see. So when you're looking at someone's EEG and you say, hey, there's a lot less alpha than I expected here, and you see that they're on this medication, that's just a potential indication that maybe this medication is decreasing their alpha, the alpha band. Okay. Again, it doesn't mean that the medication is working or not working. That's not what the EEG effects are about, right? The EEG effects are how you might discern whether or not their EEG looks different because of medication. Whether or not the medication is working is a conversation that they have with the prescribing provider, okay? Then when we look at our EEG indications, this column is going to help us figure out if we see this feature in someone's EEG, then this medication may be, again, that's may with a capital M, may be a good fit. So if you're looking at an EEG and they have fast, hypercoherent alpha, that person may respond well to this medication. They may not. That's the research tells us that a tetracyclic antidepressant or a tricyclic, if you're much older, is a better fit for this type of EEG. Now, some people who have this EEG feature may take this medication and still have it not work. That's the nature of medication. There's always a little bit of trial and error. But what this can do is help limit or cut down on some of that trial and error, okay? So when we see this EEG feature, we start to think about this medication or this class of medication. We also have some EEG cautionary factors listed. Now you'll notice for some of these, the box is blank. That doesn't mean there are none. It means we don't have that research filled in yet. And maybe someday we will, and maybe someday we won't. But for some of these, you will see that there is something here in the box for the EEG cautionary factors. And in this particular case, if we're looking at Wellbutrin, fast alpha or diffuse beta are indications that this medication may not be a good fit, that people who take this medication are more likely to run into side effects or abreactions, okay? So when you look at someone's EEG, now you can say, hey, this person has these features. I think this class of medication will be more helpful for you. And this is some of what I just talked about. The EEG effects are potential effects. You may see them, you may not. Some of the sections are blank. We just don't have the research yet. These sort of phenotypes can help guide medication choices, but ultimately symptoms and classes are the deciding factor, right? Not many psychiatrists, not many general practitioners are comfortable prescribing a stimulant for someone whose primary complaint is anxiety, okay? They're going to look at symptoms and they're going to look at class of medication. So speaking of stimulants, let's take a look. These are most commonly used in cases where people are struggling with symptoms related to ADHD, right? As a general rule of thumb, this medication class will increase beta or sometimes SMR activity, and it will typically decrease slowing. So, theta, delta. It's less effective for focal slowing and for mu, and we'll talk about that in a moment. And we want to be careful if we're using a stimulant for somebody who already has a lot of beta, okay? And I would also add here, for somebody who has a lot of fast alpha, we also want to be careful. Stimulants can make them a little more agitated. So, and I've got some examples here. We'll look at raw EEG and we'll look at power maps. If you are uncomfortable looking at raw EEG, I recommend you become comfortable. It is an invaluable tool. The power maps, the things that we see here, are useful and fun and a very interesting way to present the information to a client. But what we really care about comes from the raw data. And if that's something that you're not comfortable with, you look at the squiggles and you think to yourself, I don't know what that means, I would recommend that you do some mentoring sessions with someone who is comfortable with it. Because this map does not exist without this data set. So anytime I'm reading an EEG, I look at the raw data first, and I should already have a guess about what their map will look like before I generate it, okay? So here we're looking at frontal and midline theta. You can see it in the raw up here in FP1 and FP2, F3, F4. See it again in FZ. And when we look at our maps, we've got all this frontal theta. Usually, this is coming from the anterior cingulate. Usually, this type of brain is going to respond better to a methylphenidate class medication. So this is your Ritalin, is the most common one, methylphenidate. I think you can just buy it in patches now. It doesn't necessarily mean that if you give this brain Ritalin that the theta drops away or disappears. It just means that their symptom profile will probably improve. Okay. The other sort of class of medication that we use is sometimes referred to as a amphetamine class. So we have methylphenidate class stimulants, we have amphetamine class stimulants. The mechanism of action for those two is a little bit different. The amphetamine class tend to work more on the posterior dominant rhythm through norepinephrine. So when we do a map for someone, and we look at over here on the left at these maps, we think, oh my gosh, look at all this 5, 6, 7 hertz. This person has lots of theta. But when we look at their raw data, we see that what they really have is slow alpha. Their alpha peaks at around 7.5 hertz. So around between 7 and 8, right? That's slow for an adult. This person's 43. So that's quite slow. Now, sometimes that can drive anxiety or slow processing speed. It can also just negatively impact sustained attention or executive function. But the big thing here is that we use a different type of stimulant, a different type of medication to help this brain feel more neurotypical. They need this baseline rhythm sped up a little bit more, and the amphetamines are more likely to do that. Amphetamine class would be things like Adderall or Dexedrine. Okay. The other thing, and I put this in here because I think it's really important. A lot of ADHD cases have mu rhythm. If you're unfamiliar with mu rhythm, it is a morphological phenomena. We're going to see it here in C3 and C4. It kind of looks like the letter M just repeating itself. So I think that's where they got the name mu. That would be my guess. When you do your maps, you get to see it in sometimes called the owl eye pattern, right? It's these two eyes right in the middle of the head, okay? Mu rhythm doesn't really respond well to stimulant medication. Mu rhythm does respond, at least in one study, to intranasal oxytocin. If those, for anybody who's listening or watching, if you're unfamiliar, oxytocin is a hormone that your brain produces when you are doing things with people whom you love or care about. So when you are touching someone who you love, when you are cuddling or hugging someone, when you are even just doing things together, cooking for someone you care about, listening to music together, your body produces this hormone called oxytocin. Mu rhythm is sometimes linked to the mirror neuron network. It's a disengagement. These kids or adults are disengaged from the world around them. And so in these cases, stimulant medication doesn't really help. You can, if you're trying to go a medication route, oxytocin, but more than anything, neurofeedback and behavioral change are kind of where we want to focus our interventions here. One last note on mu rhythm before we move on. It is more common in athletes. So sometimes you may encounter someone who has ADHD-like symptoms. They're producing mu rhythm. You feel like this is the source, but you don't want to downtrain this because you will negatively impact their athletic performance. So that's a little bit of a juggle. It's also more common in soldiers and police officers. So you have to think about the sort of professional implications if you do try to address this. Okay. So that's what we get for kind of the ADHD cluster of symptoms. The next one that we see the most of, SSRIs and antidepressant class medications. So with SSRIs, they're typically used to treat depression, but also sometimes anxiety. They're sometimes used to treat OCD. They are better for people who have a slower alpha peak, like we saw in the previous two slides. If that person with the slow alpha peak, and I'll go back to just so you can see what I'm talking about here, if this person with their slow 7.5 hertz alpha peak comes in and they complain about not feeling focused or not performing well at work, maybe we want to go the stimulant route. But if they come in and they respond that they've got this frontal alpha that's driving some OCD and anxiety-like symptoms, then maybe we want to go with the SSRI, which is going to activate their alpha peak just a little bit. Tricyclics and tetracyclics are a little bit better for people who already have a fast alpha peak because we don't want to overactivate them anymore, okay? So we can look at what this looks like. What we're talking about here is frontal alpha. So we'll see again in the raw EEG up here, this is what we're talking about. In the spectral maps, you can see this one pretty clearly, 7 hertz, 8 hertz, 9 hertz. We've got it all up front, right? Now, when you're looking for frontal alpha, you have to be careful of your montage because in linked ears especially, the earlobe where you have your reference sensor will pick up on alpha activity that's generated from in or near the temporal lobes. And then it'll sort of contaminate all of your sensors with excess alpha. That's called reference contamination. So if you're a person who kind of lives in the linked ears montage, I would, one, encourage you to explore some other montages, but two, I would say that you're going to run into some reference contamination, and that's going to kind of muddy your frontal alpha picture. So just be aware of that, be careful of that when you're trying to make recommendations about whether or not someone has frontal alpha and should be taking antidepressants. Okay, the other thing very quickly before I go to the next one is here's our 8 hertz, 9 hertz. Down here you get your harmonic at 16 and 17, which tells me that this person's alpha peak is probably 8.5. And that's why your harmonic gets split between those two. So that's not frontal beta, that's a harmonic from frontal alpha. Okay. This will bring us into, oh, and sorry, one last thing. On our antidepressants, I'll go back to this one for a second. When we talk about the slower alpha peak, the SSRIs will help bump that up a little bit. If their alpha peak is quite slow, so say maybe like 7.5, 8 hertz, then you maybe want to start thinking about an SNRI. Those tend to be more activating than the SSRIs. They're sometimes used for people who have ADHD and depression comorbidity. So the SNRIs are even more activating than the SSRIs, although technically an antidepressant class of medication. Okay, then we get to anxiolytics, and this is a really lives so frequently in the autonomic nervous system. For those of you who are familiar with sympathetic versus parasympathetic activation, you know, sympathetic activation can definitely lead to a lot of anxiety. So this is a really wide class of medication. And the one thing that we really kind of want to look at here when we're talking about medication, at least, is the alpha peak. So when someone has a fast posterior dominant rhythm, you know, this is a common profile in anxiety. It's a common profile in hypervigilance, people who are wound really tight. It can be a marker for perfectionism or for rumination as well. There are a few different meds that'll lower alpha peak. One of them is Buspar, and then sometimes clonidine can do it as well, or alpha agonists if you can get those. So like propranolol. All of those things can slow down an alpha peak. And this is where the getting an EEG becomes really important. at least in my mind, for people who are prescribing medication, because you have such a wide range of medications to choose from. And people who are prescribers, who are very well experienced, have been doing this for a long time, they know how to ask the right questions and how to sort of elicit the information that they need to make a very well-informed medication choice. But for people who don't have all of that experience, or who maybe miss things in an intake, or who maybe get rushed, or they're dealing with a client who's trying to hide information, you can't hide an EEG, right? And so if you look at this and you see this super fast alpha, you can immediately jump to a medication class that might be a little bit more helpful. We also will sometimes see spindling beta, which you can see here in these big spindles. Usually we'll see this frontally here. Sometimes we'll see it in central channels. Spindling beta, so if you see this in your EEG, we do have some research that says that spindling beta is reduced when sleep is improved. So if you see spindling beta, start asking a bunch of questions about sleep. How much do you sleep? How good is your sleep? Do you wake up feeling refreshed? And don't be afraid to refer them for a sleep study, because that can yield really important information about whether or not they're recharging. But if this is not sleep related, and it's just kind of an indication that there's a little bit of an irritable cortex, they get a little bit anxious, a little bit scattered, sometimes a little bit defiant, we have found that these typically respond really well to guanfacine, which is sometimes called 10x, as well as gabapentin. Gabapentin, being extra GABA for the system, helps to calm neurons down, right? GABA is inhibitory. It stops neurons from firing so much. And beta spindles are a type of hyperexcitability. So if you can get a medication that will help to slow down that excitability, you can sometimes see benefits from that, okay? Now, spindling beta is not to be confused with diffuse beta. So I'm gonna go back and forth between these two, spindling beta, diffuse beta. And what we'll see here is that the beta in this section appears in every channel, okay? We go back and here, yes, there's beta in frontal and lateral channels, but we do see some respite. Some channels that don't have so much, where the spindles are not so pronounced. And on top of that, you see the spindles will wax and wane. Whereas here, they're much more persistent. There's just persistent beta here. And this is what we sometimes refer to as a benzo buzz. It happens when people have taken too much benzodiazepine. So things like Valium, for example. We in our clinic don't recommend benzos at all. There's not really any literature about why to recommend them based on EEG phenotypes. So this is really purely symptom-based prescribing. Given the difficulties, I'm not a prescriber, but given the difficulties that come with prescribing scheduled medications like this, it's better to just kind of steer clear, in my opinion. Like I said, we don't use them in our clinic really at all. And then we get to anti-seizure medications. So this is a really interesting class to me, the anti-seizure medication class. Now, going back to the very first thing that we started with, scope of practice. If you are a neurologist, you can say if something looks like a seizure. If you are not a neurologist, you can't. You can say, hey, this event looks concerning, and I think you should see a neurologist, but you cannot say this is an epileptiform discharge. Even if this person was having a grand mal seizure and you could witness it firsthand, you still can't call it a seizure unless you're a neurologist. That's the only person who can call something a seizure. Now, these types of discharges, we can call them spike and wave, we can call them epileptiform discharges. They're sometimes referred to as IEDs, or isolated epileptiform discharges in the literature. Sometimes they're called paroxysms, which can mean other things too. But when we see this, it means that there is a part of the brain that is inherently less stable. It's an instability. And sometimes that leads to seizures, and sometimes it just leads to messy EEGs like this. So what do we do when we see this? Well, and if you're looking at raw EEG, you're going to see this. If you're looking at maps, you're just going to see a head that has some theta or delta in it. But if you're looking at raw EEG, you will see this. It occurs, depending on the study you read, in about 10 to 15% of the population. Just across the board, everybody gets it. It is more common in people with ADHD. It occurs in about 30% of people with ADHD. So that's interesting. That probably means that it's harder to be focused when your brain is doing this. It probably means that it's harder to maintain self-control when your brain is doing this. And it probably means you're getting worse sleep too. So if somebody comes in and they say that their primary complaint are ADHD symptoms, and then you do an EEG for them and find this, you don't want to go the stimulant route. This person is going to respond to an anti-seizure medication. Now, when you use it in a psychiatric setting, this is sometimes referred to as a mood stabilizer, because when there are these discharges, you will see irritability, you will see explosive outbursts, you'll see lack of self-control. And so we call it a mood stabilizer. It's an anti-seizure medication. And what it does is it helps to calm this part of the brain. In our clinic, we use Lamictal. We'll use GABA sometimes too for this, gabapentin, but it varies clinic by clinic. This has a lot of utility. So like I said, it happens in 30% of people with ADHD. Well, if you look at the literature on autism spectrum disorder, you will find that, and it varies study by study, that this occurs in anywhere from 60 to 90% of people on the spectrum, okay? Now, I know that's a big range. Most of the awake studies are kind of 60 to 70%. There was one person, I'm sorry, I don't remember the name off the top of my head, but they did a sleep study on a population of people with autism. And they found that in that study, they found IEDs, or isolated epileptiform discharges, in about 90% of their population base. So it's much more common in people on the spectrum. What do we do with that information? Well, if those people are having behavioral outbursts, which is quite common, we want to go with the mood stabilizer versus the antipsychotic. And we'll get to those in a moment. This is less common in depression than it is in the rest of the population. It's less common in generalized anxiety than it is in the rest of the population. So anyway, really important that you look at your raw EEG, because otherwise you'll miss this. And this is a huge biomarker for a response to anti-seizure medication. And if you want to read more about this, Jay Gunkelman has published a bunch, Ron Swatzina has published a bunch, Lorianne Moreau has published a bunch. So there's a lot of people who have published on the need to use anti-seizure medications to treat isolated epileptiform discharges. And that brings us to our antipsychotics and other things that fall into the mood stabilizer umbrella. Now, most antipsychotics, especially the atypical antipsychotics, will potentiate seizures. So when you see activity like this, and you give this person, say, Abilify or Zyprexa, odds are they are going to feel worse. You'll see behavior get worse. You'll see most of their symptoms get worse, and you run the risk of potentiating a seizure disorder. This might not reach the sort of critical mass to cause a seizure, but then when you give them the antipsychotic and their seizure threshold drops, this may turn into a seizure afterwards. So for the antipsychotic class, Again, it's a very broad class, typically with, it typically causes more slowing in an EEG. So when do we want to use that? When is it good to slow an EEG down, to add a lot of delta, to add a lot of theta? Well, if you see somebody who's got beta content that is quite high or quite fast. Also, although not listed here, if you see somebody who has persistent gamma, gamma is meant to be emergent, right? You're not supposed to have gamma that is sustained throughout an EEG recording. That's usually not a good sign. Gamma should happen in bursts of activity. When it does, it means we're kind of getting it. We're having a eureka moment. When gamma is really well sustained, it's usually indicative of pathology. So we don't, when we see that, when we see sustained gamma, these antipsychotics that help to slow things down tremendously, they can be useful. But again, if we see any kind of paroxysms, spikes, or discharges, we want to kind of steer clear. Okay. I know this slide says questions. I'm happy to take questions if anybody has any. But the other thing that I'm going to show you is the actual medication guide. So give me one moment here while I switch my share. You can play your Jeopardy music if you like.
Do, 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 do.
Thank you. I appreciate that. Yeah, that was good. Okay, so there we go. So this is what the spreadsheet looks like. We go through each class of medication. We talk about what is used to treat, the potential mechanism of action for why it's useful or why it's helpful, and then the reported EEG effects and indications and cautionary factors. We have the half-life listed. We have the common side effects listed. We go through this for stimulants, for non-stimulant ADHD medications. That's things like Strattera, which is technically a stimulant, but a much, much weaker one, as well as a modafinil, which sometimes this is used for ADHD. Sometimes this is used for parasomnias or things like narcolepsy. It's an orexin agonist, so it kind of props you awake. And then Qelbree is a newer one that is technically not a stimulant. We go through SSRIs. These are used, like I said, typically for depression, but also anxiety, OCD, sometimes for PTSD. And you'll notice that for a lot of the SSRIs, we don't want to use them if somebody has a fast alpha or if their EEG is unstable. So if they're not very rhythmic, if they have paroxysmal content, we want to steer clear of these. So do your EEG first, and then you can make smarter medication recommendations that are less likely to be harmful to someone else. We go through some of the other antidepressants. In this class, you'll find tricyclics, you'll find SNRIs. The SNRIs, there has been some research about really nasty withdrawal symptoms. So be careful with those. Not for everyone, but for the people who get the withdrawal symptoms, it can be quite unsettling. So I would say use those with a little bit of caution. Make sure that if you are using them, somebody's alpha rhythm is slow. That's where we want to use SNRIs. They have the symptoms that we would reach for an SSRI or an antidepressant, but they have slow alpha. Then we get to the anxiolytics. Now, I mentioned before, this is a really broad class of medication, and a lot of different stuff falls in here. Here you'll see we don't really have any indications or cautionary factors for the benzos. We don't use those a ton. I have not come across any literature that recommends when to use them based on someone's EEG. So we kind of steer clear of those. But you'll find a whole bunch of stuff in here. Interestingly, sometimes antihistamines will show up in here, like hydroxyzine. I think that can help by decreasing the alpha peak. And if somebody has a fast alpha peak, this can kind of help slow it down. I mentioned propranolol, excuse me, for beta spindles. So you might think about this one if somebody has that kind of anxiety, ADHD, comorbidity, and you look at their EEG and you see the spindling beta, and then maybe this becomes a good fit. The anti-seizure medications, now obviously some of these are used for seizures specifically. So something like Keppra, you're probably not going to find in a psychiatric office, especially the aggressive outbursts that come with Keppra are quite big. So you want to be careful from that one. But Lamictal is one that's been well tolerated in the psychiatric community. Depakote to a lesser extent. I've seen some people using Lyrica, especially for pain, which is interesting. And then Imatrix and Topamax you'll sometimes see used for migraines as well. I know they're listed here in the anti-seizure medications, but sometimes you'll find people who come into your office taking these as an anti-migraine medication. And then you want to keep in mind, if you're trying to find a medication for migraines, if they have a slow alpha peak and you give them Topamax, you're going to run into some trouble. They're going to slow down more than they want. More than anyone wants, really. We have the antipsychotics and the other mood stabilizers. You'll see a lot of atypicals listed here. All of these are contraindicated or at least cautionary use if you see paroxysms or instability in the EEG. All of these, and some of this has been updated in the form that's going to be published by the ISNR, but usually we want to use these if there's high beta or gamma. And there's a whole bunch of names for them: Abilify, Saffris, Vraylar. Lithium is one that's sometimes used for bipolar, so you may find that in your clinic. It's a little bit of an older medication. It's not used as much these days. Latuda and Seroquel are ones that I've seen quite a bit of. Then we did include a section for opioid agonists. Now, opioid agonists and antagonists, excuse me. We don't prescribe opioids in our clinic. You may see people who come in, especially if you deal with a lot of chronic pain clients who come in on opioids. Or if you work in a substance abuse population, you may see this. So it's useful when you're trying to analyze the EEG to figure out if you're looking at drug or medication effects. But I don't know that we would recommend them based on an EEG per se. Okay. The hypnotics and the sleep aids. So with this class, you're always in a little bit of a toss-up. When you take medication to help you sleep, your sleep quality inevitably goes down. So you have to really weigh, is it better to get more sleep but worse quality, or is it better to get less sleep and better quality? And that's going to be different for every person. And it's going to be different based on how much sleep they're actually getting. So these tend to be really slow. They tend to slow you down quite a bit. The last time I gave this presentation, somebody told me there was a newer class of medication that was an orexin antagonist that seemed to work really well. But I don't know the name of it. I don't really have a lot in here for that. Antihistamines you will see during allergy season for sure. These will sometimes decrease in alpha peak. It kind of depends. Sometimes they'll increase beta. Like I said, the only one that we really see in psychiatric meds is hydroxyzine, but there's a couple others on here with noted EEG effects. So we try to take note of that when we can. And then these are a couple that I have come across just from other clients that I've seen for, they tell me what meds they're taking and we come across some new stuff. And sometimes we have information about the type of EEG effects that medication has. So with NSAIDs, sometimes they will increase alpha. They often decrease coherence. So if you're measuring coherence and you see a lot of the lines are blue, you might ask if they've been taking pain medication like Aleve or ibuprofen. Okay. So this is the guide. Like I said, I usually try to give out this guide to everybody who comes to this webinar or to this presentation. However, I would ask just for your patience. If you really, really need a copy, send me an email, but the ISNR is going to publish a full version. I'm on the committee that's working on it, so I feel okay to share a little bit of what we've done. We have added another column to our guide that will be official for the ISNR that will have research links so that all of the information is linked to the papers where we got it from, so that you can use this when you talk to other prescribing providers, other doctors, other professionals, and say, hey, it's not just me saying this, there is literature that indicates this. So we're hoping to have that done, like I said, by January. Don't hold my feet to the fire. We're all very busy, but that's the goal. Okay. So I usually end a little bit early. I know this is like a ton of information here. I am happy to take questions if anybody has any. I'm happy to kind of let y'all go if you want to go early. So there's a question here in the chat from Sammy. Is this essentially a compilation of data from published research and your own clinical findings? It's all from published research. I mean, some of this may be supported now from clinical findings, but that did not factor into what goes into this presentation. The only things that we put into this presentation were things that we could quote from a published paper that was published in a peer-reviewed journal. Now, we have found success using some of the things that are in this presentation, absolutely, but that doesn't mean that we've published on it. Other people have. I would encourage you to read, especially the work from the Tarnow Center that Ron was part of. But yeah, so anyway, to answer your question, not really our findings in this presentation, just the published research. So the question is, for your initial QEEGs, do you have clients take their meds later that day? No. And the reason for that is because I am not a medication provider. And I don't want to tell someone when they should or shouldn't take their medication, only to have them misunderstand my directions or have the doctor get mad at them. If they have a medication they're supposed to take at night and I mess up their ritual, I don't want to put my toes into any of that. So I tell everybody, take your meds like normal. We will look at the EEG and try to figure out if there are medication effects. But yep, stick to your meds as normal. Other people may do it differently, and my answer might even be different if I was a prescriber, but as it is, I don't feel comfortable having that conversation with clients. I will tell people, wait on your coffee if you can. If you're a coffee drinker, try not to drink coffee right before your EEG, because coffee can sometimes increase beta. And so we don't want to peg someone as having a beta brain when they don't. But for medication, I just tell them take it as normal. And that also extends to some people that we see will take medication during the week, but not on the weekends. Like we see some kids who take stimulants when they're in school, but not on the weekends. And if they come into the clinic on a weekend for an EEG, I tell them, if you don't normally take it on this day, then don't take it on this day. Like, just stick to your normal routine. I don't want to take on any extra liability when it comes to managing meds that are not mine to manage. Does the time of the EEG matter for medication? What a good question. Yeah, so in the guide, and let me see if I can share this one more time. Here you go. So we have listed the reported half-life of each of these meds. And the reason that we put this here is because we want to know how much of this medication is in your system. Now, sometimes we see people who are changing medication. And so we want to know, is there still some traces of this medication in your system or not? Typically, for a med to completely wash out, you need 7 half-lives. Now, for something like 10 to 30 hours, that's a range that's harder to figure out. But for something like 15 hours, okay, 15 times 7 divided by 24, that's your washout period. And sometimes we have done EEGs for people where they want a med washout, so that they can see what their brain looks like without meds. And so we might tell them, hey, we had you scheduled Monday, but that's not within the washout period. So come back next week and then we'll get you in. But that, that's if that's the specific goal. The half-life is, what that means is how long does it take for the medication to be present by half. So for Strattera, I always ask, when's the last time you took your medication when I'm doing an EEG for someone? And say if they're telling me they take Strattera and they took it 3 hours ago, okay, well, it's not even one half-life. I expect to see some trace of that. But if they tell me, oh, I took it yesterday, well, that's 24 hours. That's 4 half-lives. I should expect to see, if we're going to increase beta, that effect should be much, much smaller. So it's important to know when they took their medication. And I definitely ask that anytime someone does an EEG. Yeah.
For that, I kind of have a follow-up question for that.
Oh,
So
sure.
if you do, for the same example that you provided, it's like they've just took their medication, I guess one half-life ago, so like 5 or 6 hours.
Mhm.
Is there a way, like obviously you're kind of looking at the EEG and trying to see like, okay, assuming this medication was taken, your beta is probably going to be a little higher. Is there like a systematic way to do that instead of just guessing?
Oh, like, do you mean when you're looking at the EEG, or do you mean
Right.
latency of the medication?
I guess when you're looking at the EEG.
Yeah. So the short answer is no. Now, other people in this field will tell you a different answer, right? Some people will talk about comparing linked ears to a Laplacian montage, and by that comparison, you can figure out, because Laplacian is local, linked ears is global. You can see local effects versus global effects, excuse me, and that should be able to help you determine which effects are medication based and which ones are directly from the brain. I think that is useful to an extent, but also if a medication increases beta, no matter what montage you put it in, you should still see extra beta, right? That's the effect of, that's what the medication is doing. You can't montage your way out of medication effects. So we compare an EEG across multiple montages, but we do that for everyone every time anyway. So what we're really looking for is, do we see things that sort of don't fit the pattern, right? Like, oh, wow, this EEG is really slow. There's a lot of delta. This isn't that precise when it comes to measuring medication. Medication isn't that precise. So we try to do what we can to figure that out.
That's fair. I was gonna say, how the medication or how your brain or takes in the medication is probably different for everyone anyway. So trying to get anything similar or like more generalized is a feat for sure.
For sure, yeah. And one of the things that I have struggled with is when we look at something like, say, a dopamine agonist, right? So a stimulant is typically a dopamine agonist. It means that it helps to keep dopamine more readily available in the synapse. So what if that person is dopamine deficient because the dopamine is getting taken away too quickly? And another way to, so some of the stimulants are also what are called dopamine reuptake inhibitors. So they stop it from getting taken away too quickly. So it's probably a good fit for that person. But what if that person is struggling because they're not making enough dopamine in the first place? Then if we stop the dopamine from going away, maybe it's helpful to have it kind of laying around extra, but maybe you're trying to kind of squeeze blood from a stone, so to speak, right? You're squeezing the pipeline as much as you can, and there's not enough dopamine to come out in the first place. And so if that's the case, is that medication going to help them? I don't know the answer to that question, and I don't know how we measure that in the first place. But it's something I've thought quite a bit about when it comes to medication is this a demand side problem, or is it a supply side problem? And I think as we move forward, we're going to find a lot of utility in doing things like an organic acid test or a neurotransmitter production test to make sure that before we try to give someone a way to boost dopamine, we need to make sure that they are building the dopamine correctly in the first place. And then we can kind of use that dopamine reuptake inhibitor to really get the desired benefit of the medication. But I think we need to start thinking about medication from a supply side first. Are we building these building blocks correctly before we even get to reuptake or agonist or antagonist type stuff?
I feel like it should be one of those, like a simple thing like, oh, when you're checking a car or checking a computer, not obviously not the same thing, but there's like a input output kind of way. So there's like different steps where you can check like if something's wrong here, something's wrong here, something's wrong here. But because our brains are so abstract in a way where we can't really get to like nitty-gritty details, it's hard to just like throw things at it and see what sticks, which is kind of what medication feels like most of the time.
Yeah.
Um, but I think that's a great like stopping point. So thank you so much, Corey, for your time.
Yeah.
And for everyone who is going to be watching this in the future.
Yeah, absolutely happy to help. And then I'm always happy to talk about this stuff more. So if anybody has questions, give me a call, shoot me an email, and I'm happy to try to answer whatever questions I can, and maybe have a longer or bigger conversation about it.